Hi guys, so today we are going to be doing another video in the Think Like a Medical Registrar series where I teach you how to think as a medical registrar, okay, and how to prioritize on the common presentations that you will get in PACES and in real life, okay. So today we're going to be talking about cancers, just generally all cancers, malignancies, all right. So this video will help you towards your exam as well as your real life situations where you will be dealing with this on your medical take and on your wards. So stay with me until the end. For those of you who don't know me, my name is Dr. Vishal Kumar. I am the founder of Keen Medic, the YouTube channel, and also keenmedic.com, where you can find my PACES course and my book. So let's get started. So in this video, we're going to be talking about the important questions that you need to ask first in anyone with suspected cancer or with known cancer, okay? Then we'll talk about the investigations, management and special considerations for cancer specifically, and then a quick summary to finish off because we will be covering quite a different number of aspects of cancers in this video. First of all then, so the important questions for cancers is the first thing that you need to know is primary location, okay? Where is the originating source of the cancer? This may not be always known, okay? So it may be that patients have cancers of unknown origins, or they may have a first presentation with suspected malignancy. And you may investigate this in your in their time in hospital, or they may be investigated as an outpatient, and that may be an ongoing thing, or they may have had extensive investigations, and still the primary source may not have been found. This is also possible, okay? So the primary location, if it is known, followed by the metastases, whether or not the cancer has spread anywhere, whether that may be local, it has grown to a size where it is obstructing local structures and has gone to the lymph nodes locally, or has it spread to lymph nodes elsewhere around the body, for example, above the diaphragm, below the diaphragm, etc. Or has the cancer gone to other solid organs? Typically, a lot of the metastases happen to areas such as the lungs, the bones, the liver, and the brain. These are the typical areas of metastases. Okay. So followed by what you should be thinking about is the treatment. Now they may not have had any treatment at all for whatever reason. Maybe they are waiting for oncology to commence treatment and there is a treatment plan in place, or they may not have seen oncology at all and there is no treatment plan in place, or they may have had treatment so far and you just need to find out what the treatment they have had so far is, okay? And speaking about treatment, if they are known to oncology, what you should be finding out is what is the intent of the treatment, okay? Whether or not this is curative or palliative. Now, this point I've highlighted, it's all in capitals and it's underlined because it is extremely, extremely important. So make sure you pay attention and note this down in your mental bank of information. For this is important both for PACES and also real life, because if, let's say, the intent of their treatment, whether that's chemotherapy, radiotherapy, surgery, etc., was curative, okay, then that means that the chances of their recovery is good, and that means that you should be treating them like any other person, okay, without cancer. So their treatment escalation should be to level 2 or level 3 care, depending on their physiological baseline, that kind of thing, okay? Versus palliative. So if it is palliative, let's say they have had chemotherapy, which is palliative, or they are just purely on palliative medications, then that means that their prognosis is unlikely to be good. Their prognosis is likely to be quite limited. Their lifespan is likely to be quite limited. Okay, that's what this tells you. And that means that their escalation plan, which is what we're talking about next, their escalation plan, so that should be also limited. perhaps escalating them to level 2 or level 3 care may not be the right thing to do. Okay, so that's what you need to find out, and often patients will know about this, so you can find out from them, from their relatives, or the oncology team, if they are known to the oncology team locally. All right, of course this point is only relevant if they have been under the care of the oncology team already. Okay, if they have not even seen the oncology team, then the first step would be to get them to see the oncology team. If they if you found a cancer, if they have not seen an oncology team at all, then you wouldn't know this, would you? So that's only relevant if they are known to the oncology team. Okay, so that's the important point here. All right, so what investigations should you be doing in someone with cancer? So these are for patients who are not immediately end of life. Okay, so if someone has got significant cancer, malignancy with or without metastases, and they are end of life, then these investigations are not really relevant because you would just treat their symptoms, okay, and just keep them comfortable essentially. So these are for patients who are not immediately end of life. So these are first and foremost blood tests, so just basic blood tests that you would do for anyone else. Okay, so these would be to look for things like anemia. So if they are anemic, then you would think about transfusing. If they are neutropenic, most likely because of a recent chemotherapy, medication or session, then you would need to treat them, especially if they have been pyrexic, then you would need to treat as neutropenic sepsis, right? And if you're treating as neutropenic sepsis, important things are things like blood cultures and IV broad spectrum antibiotics. Typically, this is tazocin in many trusts in the UK, but follow the local guidelines, okay? All right, so if you're ever not sure in your examination setting, just say you would follow the local guidelines for antibiotics. Don't just assume it is something when it's not. That is a risky move to make. So just say I would follow the local guidelines for neutropenic sepsis. And hypercalcemia, of course. So hypercalcemia can happen in lots of malignancies, including lung cancers and also other malignancies with bony spread. So you should treat the hypercalcemia because patients may well be symptomatic with it, with your typical features of hypercalcemia, such as general aches and pains, renal colic, dehydration, abdominal pain, things like that. All right. So hypercalcemia, the treatment would be lots of IV saline, followed by pamidronate if need be. All right. Next, you should think about imaging like anyone else. Okay, so the imaging of choice usually is CT, chest, abdomen, and pelvis. That's what it stands for, CAP, chest, abdomen, and pelvis, because that will tell you whether or not they have got metastases, but that will also tell you a lot of other relevant and important information, things like whether they have got bowel obstruction. Important if you are having if you have got a patient with vomiting and constipation and abdominal pain. Okay, if obviously they have got bowel obstruction, you would keep them nil by mouth, put down an NG tube, nasogastric tube, for decompression, and get a surgical team to review urgently and put the patient on intravenous fluids because they would be nil by mouth. Okay. If it shows biliary obstruction due to liver mets, then you would think about putting them on IV antibiotics. If they are septic, you would think about, again, review by the surgical team or the gastro team to see if they need a stent put in place, that kind of thing. And also SVC, superior vena cava obstruction. So this can happen in typically lung cancers, which are seated at the apex. Okay, so you would think about steroids or urgent radiotherapy. This would need to be organized by the oncology team, the radiotherapy, and you would also think about steroids, which again should be dictated by the oncology team. Okay. The other thing that you can do for SVC obstruction is urgent insertion of stents. So this is typically done by the interventional radiologist. So this should be consultant with the oncology team and the interventional radiology team in your center. If your center does not do it, then you should find out where your local center would be. Okay, this is typically done in tertiary centers. All right, CT and MRI head, again to look for cerebral metastases. Now, patients with cancers can often be confused, and they may be confused for many different reasons. Even things like, neutropenia, if they're septic, if they've got hypercalcemia, but they may also be confused because they have got metastases in the brain, which you may or may not know about. Okay, they may come in with new onset of confusion on a background of some kind of known cancer. Then you should be thinking about whether or not you've got metastases in the brain. The way you would find out is by doing a CT head with contrast or MRI head. CT head on its own without contrast does not usually show up metastatic lesions. So that's what you need to be thinking about, CT head with contrast, okay? Next thing is MRI spine. If they have got any kind of back pain or loss of control of the bowel or bladder, which is new, settle anesthesia, sensory loss in the lower limbs, motor loss in the lower limbs, things like that, then you should be thinking about cauda equina syndrome, because they may have metastatic lesions to the spine, which may be compressing on the spinal cord and causing cauda equina. This, of course, is an emergency, and this needs to be urgently reviewed by the orthopedics team for any decompression that may be needed. And you need to also discuss urgently with the oncology team, because you may need to organize urgent radiotherapy to the spine to reduce the swelling and the mass effect. You would also put them on dexamethasone to reduce the swelling around the metastatic lesion. Okay. All right, endoscopy should be considered if you have done things like CT cap and you are thinking about whether a patient might have an esophageal obstruction. Now, esophageal obstruction would also show up on the CT cap anyway, but let's say you have not done CT cap and you are thinking about possible esophageal obstruction because they are known to have esophageal lesion, which has not had any intervention of recent times, and they have come in with vomiting and not being able to swallow. Then you should be thinking about esophageal obstruction and getting the gastroenterology team involved for a possible endoscopic intervention. So let's talk about management. So we've actually covered a lot of the management aspects already in the investigation section. So this will just be a bit more of supplementary information. So the first thing that you have to do with any cancer, especially if it is a new cancer, is MDT. That is absolutely crucial. No cancer which has been newly diagnosed should be managed without the outcome of a multidisciplinary team meeting. Okay, that is a requirement. That is absolutely vital. Okay, you are not a specialist. Okay, you are not a specialist in PACES. You are not a specialist in real life as a medical registrar. Okay, so you need to always be putting every case through the multidisciplinary team. Even if you are an oncologist, you don't make the decision on your own, okay? In every new cancer, we're talking about a newly diagnosed cancer here. So every new case needs to go through the MDT team. And of course, you need to involve the patient and the family. Whatever the MDT outcome may be, if the patient and family feel that they don't want any further treatment, then that would supersede the MDT's advice, essentially, because some patients, although the MDT outcome may be of chemotherapy or radiotherapy, some patients may not want treatment for their own personal reasons, and that is something that you have to respect. Okay, as the clinician, as long as the patient has got mental capacity, you have to respect the patient's wishes. So you always have to involve the patient and the family in the decision making and when it comes to management. So I'm going to break it down into 3 options so that it's very easy, very clear for you to remember. First and foremost is the most invasive, the one with the most risk, okay? And that would be the surgical option. Now, this is not something that you would dictate. Again, that is something that would need to go through the MDT. So this is just something for you to be aware of. Now, surgical options are usually only done and performed if the lesion, the malignant lesion, has not metastasized elsewhere or is not invading and causing significant issues, okay, and only if it is safe, relatively safe for the surgeon to perform the excision of the lesion. Medical therapy, of course, would be chemo and radiotherapy. This is dictated and organized by the oncology team. Okay, so medical is largely oncology driven. Last is the palliative. So this would need to be dictated by the oncology and the palliative care teams. So at this stage, the palliative care team would also need to be involved. Now, bear in mind, palliative care can happen at all three stages. Okay, not just it's not necessarily a progression. Palliative care can happen at the surgical stage as well. All palliative means is it's a controlling of the symptoms. So symptom control is the key thing, okay? So this would be by a number of different means. You can transfuse the patients if they are anemic to help improve their symptoms and improve the hemoglobin count. You can give them various medications, things like ondansetron to help with vomiting, glycopyrronium to help with secretions, morphine to help with pain and shortness of breath. Okay, so things like that, lots of different medications. And if they are end of life, then the palliative care team can also set up an advice on syringe drivers. This can be as inpatient and outpatient. Okay, by outpatient, I mean things like hospices, which again, you won't necessarily deal with. Also, palliative procedures are a thing, okay? So just because a patient is palliative does not mean that they are end of life necessarily. End of life and palliative are not mutually exclusive. There is an area of overlap. So palliative procedures may also involve drains and stents. Let's say a patient has got recurrent pleural effusions, then you may put in a pleural drain, indwelling pleural catheter, which is a type of drain, okay? Or you may do a once-off chest drain. So this is a palliative procedure to help relieve the symptoms. Okay, this is not curative. The intent is not cure. The intent is to control the symptoms better, and that in itself is something actually very important for you to be aware of, because at the end of the day, the patient is your focus. Okay, and even if that means improving their symptoms, then that is important, okay? You are not there to necessarily cure every single time. You need to also be thinking about improving their symptoms. Stents. So stents may be in the form of esophageal stents for esophageal malignancies, biliary stents if if the biliary tree is compressed by liver lesions, or even colonic stents, or SVC stents. So stents can go really, anywhere in the body depending on the site of the compression. This is again not dictated by you. It is something that should go through the oncology and interventional radiology teams that you need to discuss with. All right, I hope that makes sense. Let's move on to some special considerations. First and foremost, as I mentioned earlier on, symptom control is always important. Okay, symptom control is essentially palliative care. Palliative care needs to be done at every stage of the process. Patients need to be on top of their symptoms as much as possible, even if they are having active treatment with surgery. Education of complications like neutropenia is important for them, for the patient, and also for you to manage these complications, because the complications can happen as a result of the cancer itself, things like hypercalcemia, or due to the treatment that they are receiving, things like neutropenia. If there's any kind of edema around the metastatic sites or even the primary sites due to the cancer itself, then you would consider dexamethasone. Okay, this should be dictated by the oncology team. If you can't get hold of the oncology team, or they are not around locally, or it is out of hours, etc., then just follow the BNF and give them a loading dose of dexamethasone intravenously, followed by twice daily doses for the next few days. Okay, but before you give them dexamethasone, you need to have confirmation of some kind that there is a lesion, a malignant lesion with edema around it. Okay, so that means that you need to get an image of some sort. So this may be a CT or an MRI, and this may be of the head, the body, whatever. Okay, so you would put them on dexamethasone and also consult the oncology team. Now, a lot of hospitals have got something called the acute oncology team, which are nurse-led. These are specialist nurses in acute oncology. They are extremely valuable to the team. They are very knowledgeable, and they are also very resourceful. They can advise on a lot of symptom control and management, and they can also liaise with the oncology team and also the palliative care teams. And often, they are there Monday to Friday, most days. So it is very valuable for them to be involved. So do mention them, even if you forget to mention oncology for whatever reason. But both should be involved in the management of the patient if they have got cancer. All right. We have covered loads today, so I want to just make sure you're okay with what we have talked about. Let's just go through a quick summary of everything then. First and foremost, find out what the intent of the treatment is, okay? Know where the primary is, if possible, know where the metastases are, and know what the treatment intent is, whether it's curative or palliative, all right? Look for metastases and the complications that can be caused by the metastases, the cancer, and also the treatment they may have had, like neutropenia, and treat these complications. Always treat these symptoms, okay? Whatever the symptoms they may be having, whether that is because of the cancer itself or because of the treatment that they have had for the cancer, always treat the symptoms, regardless of whether you are dealing with a patient who is having active treatment with surgical interventions or they are end of life, okay? Treatment of the symptoms is important for every single one of them. MDT is your mantra when it comes to cancers, and especially new cancers, okay? New cancers will always have to go through MDTs. If they are old cancers, then always seek the advice of the oncology team, who may well want to get them through the MDT again, all right? Uncertainties of any kind always involve the oncology team. Don't take the sole responsibility because you are not a specialist. You need advice from them. I hope that makes sense, guys. We have covered loads. If you want to learn more, then make sure you check out my book, which is available on the Kindle format and also in paperback. It is on strategies for high achievers for PACES, and also my course, which is loaded with features. Both will be linked in the description down below. I will see you in the next video.